Hello friends, welcome to another important topic, that is brainstem evoked response audiometry and otoacoustic emissions. Basically, what are these two? These two are important investigations regarding diagnosis of hearing loss. So it is also a very important question from the exam point of view. So let's discuss these two entities in brief. So what is BERA? BERA is basically brainstem evoked response audiometry. There are other synonyms also, such as ABR, that is auditory brainstem response, and there are a few other synonyms, but I will not go into much more details. Let's understand the basic concept. So what we do in the BERA, basically we present a stimulus in the form of pure tone, and in response to that stimuli, we basically record a neurogenic potential using suitable electrodes in response to that stimulus which we have given in the form of pure tones. So basically, how we can record the neurogenic potentials, we will record it with the help of electrodes. So what are the electrodes? We will see one by one. There are basically three kinds of electrode. Number one is reference electrode, second is active electrode, and third is ground electrode. So what is a reference electrode? It is placed in the ear to be tested. Active electrode is placed at the vertex, and the ground electrode is placed in the opposite ear. What are the parts of BERA? The number one is signal generator, which will generate the pure tone stimulus. Second is the amplifier, which will amplify the pure tone. Third is computer, that is also averager. And fourth part is displayer, on which the waves will be displayed. There are various waves we will see in the further slides. And last part is the printer, by which we will print the graph of BERA. So what are the advantages of BERA? BERA is not affected by the sleep stages and any kind of medication influence or presence of general anesthesia. So these are the few advantages that reduces its limitation over the conventional tests such as pure tone audiogram and others. So now coming to the procedure, how we will perform the BERA. Basically, the earphone will be placed in the test ear, which will deliver uh, approximately 1000 to 2000 clicks at the firing rate of 5 to 50 per second. In response to that, there will be waves generated. What are those waves? Wave 1, wave 2, 3, 4, 5 and 6. There are particular places which will give origin to those waves. Wave 1 will be originated from the acoustic nerve. Wave 2 will be originated from the cochlear nucleus. Wave 3 will be originated from the superior olivary complex. Wave 4 from the lateral lemniscus. Wave 5 from the inferior colliculus, and wave 6 from the medial geniculate body. Previously, we have also used mnemonic, that is E colima. So on the basis of E stands for eighth nerve, C stands for cochlear nucleus, L stands for lateral lemniscus, I stands for inferior colliculus, and M stands for medial geniculate body. So from that mnemonic also we can withdraw the inference about these waves. So here you can also remember from this table that from which nucleus or nerve that particular wave is getting generated. So it is important to know that from which nerve respected waves are getting generated. So out of these waves, the fifth wave is last to disappear, and it is also the most robust wave. So now coming to the response, that what are the response we can withdraw from all these waves. So there are various responses. Number one is absolute latency. Next is interwave latency delay. Third is interaural latency difference. Interaural means the latency difference between both the ears, right and left ear. Next is amplitude ratio of the wave, and the last one is the morphology of the wave. So among all waves, we usually see that latency of wave 5 is most consistent. So it is a very important wave to study about the characteristic of BERA. So let's discuss about each and every response. Among which waves the interwave latency is best studied, that is between the wave 1 and wave 5. Normal value for the interwave latency between these two waves is 4 millisecond. If there is any enlargement, that is value of more than 4.5 millisecond, that becomes the pathological, that indicates there is any kind of disease. Also, more than 0.29 millisecond interaural latency, It means latency between the right ear and left ear. That becomes the diagnostic of retrocochlear pathologies. Now coming to the point that we have previously discussed, why fifth wave is very important to study. It is very important because it is most reliable, most robust wave. It is very easily reproducible, and it is the last wave to disappear from the whole test. So that is why it is very important. Also, what is the normal amplitude ratio of the wave? Normal ratio is 1. If there is amplitude ratio is less than 0.5, then it becomes abnormal. Now coming to the uses of the BERA. So what are its applications? Basically, it is used to detect retrocochlear pathology such as acoustic neuroma, and it is also used to confirm brain death, to rule out malingering, and also in deaf child to identify the threshold value of hearing. Now, coming to the characteristic points in various kinds of hearing loss. So, if a patient has conductive type of hearing loss, what changes we will see in the BERA? In conductive hearing loss, wave 1 will be absent, and there will be prolongation of absolute latency of each wave. Coming to the retrocochlear pathology. So, in case of retrocochlear pathology, what peculiar changes we will see in the BERA graph? There will be prolonged wave 5 absolute latency, prolonged wave 1 to 5 peak, that is the most sensitive parameter, and the amplitude ratio will be less than 0.5, as previously also told that if it is less than 0.5 it is abnormal, and there will be distorted morphology of all the 5 waves. So these are the few important applications and how to discriminate between the conductive and sensory neural hearing loss on the basis of BERA. So here it is a normal waveform image of the BERA. On the horizontal x-axis, we can see the latency is being plotted in the form of millisecond, and on the vertical y-axis, there is generated potential in the form of microvolts. So here we can see almost 1 to 7 waves, out of which the fifth wave is seen, which is most robust, and it is also most reliable and most consistent waves. So coming to another graph of BERA. So here there are three waveforms of BERA are plotted. The first one on the topmost is normal BERA, and the second and third ones are abnormal. Why it is abnormal? We will see. As here we can see there are three different waves in this waveform. That is wave 1, 3 and 5 are only visible. And on comparison of the interwave latency, basically to check the interwave latency, simply you see the distance between the two waves in the plotted graph. So clearly, if we compare the topmost image with the second image, there is clearly a big gap between the wave 1 and wave 3. So there is prolonged interwave latency of wave 1 to 3, and also between wave 1 to wave 5. We are comparing the second graph with the first graph. Okay, so here is increased interwave latency. Also there is flattened peak of the wave 5 in the second image. It means there is reduced amplitude of wave 5 as compared to the normal BERA. Okay, so in this way, as in the third image also you can compare, there is increased interwave latency. Just see the difference between the distance of wave 3 and wave 5, and also between the wave 1 and wave 5. Compare it with the first one, topmost image, that is normal. See, the wave 5 is lying much ahead as compared to the normal. Okay, so increase the distance, increase the latency, and also there is flattened peak of these different waves. That means reduced amplitude. So all these abnormalities indicate towards a pathology. Okay, so this was the image depicting the abnormal waveforms of BERA. Now let's proceed to the otoacoustic emissions. Coming to the next important investigation, that is otoacoustic emission, or in the short form we also know this as OAE. So what is otoacoustic emission? It is also known as campsichose. Basically it is a sound waves. These are the sound waves emitted by normal cochlea. It can also be generated without any stimulus or in presence of stimulus. Okay, so these are known as otoacoustic emission, that is sound energy emitted by the normal cochlea. So how we will measure this sound energy? We will measure it with the help of some instruments. So what are these instruments? Number one is probe tip that has to be inserted into the external auditory canal of the patient, and a computer, and there will be a microphone. So what are the two different kinds of otoacoustic emission? Number one is spontaneous otoacoustic emission, as we have also discussed that it is naturally generated sound energy by the normal cochlea. Second is evoked otoacoustic emission, that is the sound energy emitted by the cochlea in response of certain stimulus. Okay, so what are the characteristic points of spontaneous otoacoustic emission? It happens only in 40 to 60% of normal cochlea. Okay, not in 100% of normal cochlea, it occurs in only 40 to 60%. What is the frequency? That is approximately at 1 to 2 kilohertz. Also, it gets inhibited easily by the ototoxic drugs such as aminoglycoside or loop diuretic salicylates, etc. And also with the increasing age of the patient, this spontaneous emission gets reduced. Okay, so this was the spontaneous otocaustic emission. So the other type is evoked emission. It is of again two types: transient emission and distortion product emission. What is transient emission? It is seen in normal to almost mild hearing loss. And what is distortion product emission? It gets elicited by the two stimulus which are given simultaneously to the cochlea, and it is delivered at intensity of 55 to 85 decibels. There is very small latency will be there between these two sounds. They are presented almost simultaneously. So of these two sounds there will be a distortion product that will generate the these emissions known as distortion product otoacoustic emission. Absence of any kind of emission waves that indicates abnormal middle ear response or abnormal cochlear function. Coming to the uses of photoacoustic emission, it is mainly used in as a screening tool in neonates for sensory neural hearing loss. It is also used to rule out malingering and to differentiate between the cochlear and retrocochlear lesion. Ideally, the optimum time for screening in newborn is after 24 hours of birth. Okay, so what are the its advantages? It is very less time consuming, almost 2 to 3 minutes to test the both ears, and it is a non-invasive procedure. Okay, so what are the few drawbacks of photoacoustic emission? As it is a qualitative test, so it can't quantify the hearing loss like audiometry or other investigations, that what is the exact degree of hearing loss. Okay, so and it also can miss the very mild hearing loss. It is also gets affected by the middle ear pathology such as middle ear effusion or retraction, etc. So these are the few drawbacks of photoacoustic emission. So this is the image of OE machine. As here we can see patient is lying down and there is a handheld device in hand of examiner, and the ear probe tip is inserted into the ear canal. It will receive the sound energy emitted by the cochlea. It hardly takes 2 to 3 minutes to test both of the ear. So that was all about BERA and OE. Do ask in the comment section if anything is difficult to understand for you guys, and follow us this channel for more such useful contents. Thank you.